Okay, good evening. Thank you, Dr. Sheikha. Thank you for a kind invitation, and thank you for sticking around. Probably a very long afternoon. Everybody wants to leave, so we'll try to make it as short and easy as possible. So I was given the task to talk about how to interpret the DEXA scan, basically. So once you get the report that has maybe 3-4 pages of information, it has diagrams and tables and images. So I'll try to come up with a good interpretation about this test, and not just to stick, which I try to avoid as much as possible, just reading the summary of the DEXA scan, because a lot of it could be misleading. So the DEXA scan is a gold standard method to measure BMD. And when I say gold standard method to measure BMD, I don't mean the gold standard method to diagnose osteoporosis, because two things are different. So to look at BMD itself, the thickness of the bone, the best tool you have so far is to look at DEXA scan. To look for the diagnosis of osteoporosis, you need to interpret also clinical situation and the clinical settings of the patient. Okay? So here we're talking about thickness of bone and measuring BMD, not specifically diagnosing osteoporosis. So it's a gold standard for BMD measurement. It has an excellent reproducibility, meaning whenever you bring the patient to do another scan, it will give you the same result. You bring him next year or within a short period of time, you probably also get the same result. So that's why it's a good reproducibility. It has a known technology used in most trials, so we can use it to predict fractures. We can use it to monitor therapy. So it's a good tool for that purpose. It measures central sites, where in the center in the body, the spine and the hip, and also uses peripheral sites to measure also, which are the forearm. We use it for three main reasons. We use it to diagnose osteoporosis. We use it to predict the risk of fractures. And we use it also to monitor therapy on patient on therapy for osteoporosis. This is basically the scheme and how it looks like. This is a characterization of how the DEXA scanners. You have a box which actually delivers the X-ray source, which is like a regular X-ray. So it delivers the X-ray source. The difference about how it's different than regular X-ray is the calibration, or the coulometer, we call it. It was actually the one that actually gives different waves on how these X-rays, when they leave the X-ray source. It goes through the patient on the table, and then it goes to the detector. And this detector also grabs this information that comes from the energy box through the patient, and then subtracts or takes away soft tissues and bones. And that's why it gives you the impression of the BMD and the thickness of the bone. Now, the technologies are different, and maybe in your hospitals you probably have a GE or you have a Hologic. Some hospitals in the past have Norlands, and some privates also, some have them. So these technologies use different energies. So the energy box could be different. The collimator, which actually diverts these X-rays, also could be different technology, and also detector could be different. So that's why these machines are not easy to compare them one next to each other, unless there is some kind of cross collaboration between these technologies, so you can actually come up with a good unified answer between all these. It has, if you're comparing or using this, the standard deviation of the means, there's also different, because the population they're comparing with them, they're also different. And the inter-device variability could be also different among these technologies. There are relative contraindications, pregnancy. Recent contrast study, which usually when they go into this testing, they block the spine specifically, so we don't want to do an imaging of a density when their spine is full of contrast, because it which increases the density of the spine. So you want to wash it out maybe for 72 hours. Recent nuclear medicine scan was also can distort the images. Extensive orthopedic instrumentation. So you have multiple spines, instrumentations. You don't want to look at the spine because it just has many instrumentations in the spine. Similarly to the hip, either one of both of them. The body weight greater. Now the newer machines can acquire or can handle much more heavier patients than before. So I think this limit is much larger than before. But in case some patients cannot be situated on the table, on the exam table for any reason, then we can use the peripheral arm or the forearm, which is a peripheral site, to look for the bone density itself and look for the scores that we want on a sitting position, because those patients don't have to be on the table. They can sit next to the table and have the forearm scanned. In every DEXA scan, there should be 2 locations scanned to call it a complete study. Okay? So you need on every patient to have a spine scored or examined between L1 and L4, and also the hip, the total hip, and the femoral neck. That's the basis, or that's the minimum requirement of a normal DEXA scan. In some patients, you want to get the third of the radius, so we will show you the location in the images. In patients, we cannot get a hip or a spine, we cannot measure them because they had instrumentation, they had a fracture, they cannot lay down on the table, then we can do the forearm. In cases of hyperparathyroidism, because the high PTH acts more on cortical bone, and the forearm is about 90% cortical bone, so you'll see the effect of the high PTH causing resorption more in the forearm, where in the spine is 90% trabecular, so it has less action on the trabecular. The hip is kind of 50-50 mixed. So you see more effect on the cortical bone in the forearm. Very obese already, we discussed that because of this situation of these patients. So the DEXA printout comes out like this. So it will tell you the name of the center that was done. It has to. It will tell you the demographic information about the patient, and we'll talk about that. Then you will have the scan information, and the scan information tells you who did the scan, what time was it, what was the date, all the scan, what type of a scan was done, if there was a specific software, it will mention that in the scan information. Then you have three important parts, which is the image of the X-ray, and you have the detailed DEXA scan results, we'll go through them, and then you have the graph to estimate the risk of fracture if that's needed to be done. So positioning is very important to have a successful DEXA scan reading, because without normal or appropriate positioning of a patient, then you will have either a distorted image or even a BMD value or a DEXA scan value that is not correctly labeled. So in this lumbar spine, patient should, the center of the patient should be on the scanner table, the aligned patient with the scanner axis, so it has go just exactly, this is the scan axis, so the patient has to be laying on in the same line. The legs could be raised with any kind of instruments, so we can actually have the hips and also the spine at the straight position. And when we look at the images, or when we do the scan of the lumbar spine, there's what we call the region of interest, which is these areas that we use them to predict the risk of fracture, or we use their scores to tell us the diagnosis, basically. So the regions of interest is between L1 and L4. There are, we call points of interest. Points of interest, you like them to be there in the image, so you can actually make a judgment that the image was done correctly. Without each point, you will be skeptical. Maybe this is one not done correctly, maybe there was an error in the picture. So out of these points of interest, you would like to see the ribs, especially T12 ribs here. So you have to see them so you can actually know that the image was done right. The iliac crest, which is here at these points. So if you have these points of interest, then you will know that the scan was done in the right way. This is the hip positioning. It's important that the hips has to be, the legs has to be abducted and internally rotated slightly. So that will be the proper positioning of the hip. And in the region of interest that we look for in the hip is the femoral neck, which is this rectangular box, and we'll tell you how it's different between machines, and the total hip, which composite of femoral neck, Ward triangle, trochanter region, and the intratrochanter region. So that's what we call the total hip area. Okay. So these are the two regions of interest we mentioned. Then you have points of interest that also you would like them to make sure that the exam was done correctly. The lesser trochanter, and the lesser trochanter is a posterior object. So if you see more of a lesser trochanter, then you know this patient is not done internal rotations quite good. So he's more of externally rotating his leg. Also the ischium, you would like to see it also to make a good judgment about the picture. In the GE or the hologic, they have different way they place they're different in where they place the rectangular or the box for the femoral neck. So in hologic, they attach it or they anchor it to the greater trochanter. But in the GE, it actually has to fit at the tightest or the smallest part of the femoral neck. That's you can make a judgment that the placement of this box of the femoral neck was done correctly based on the machine that was used. The forearm positioning is much easier than the others because there's a kind of stabilizers for the forearm, and they just have to be straight. We like to use the non-dominant arm because it's less influenced by activities and weight and exercise. Then you can see the true density of the bone. And in the region of interest for the forearm, we would like to look at the third of radius at this area right here. And there are some areas that's still in research that probably might have a link to increased risk of a fracture if they are monitored. They call the ultra-distal area of the radius, which is right here, and the mid-radius also right here. But the one that is actually can be used and linked to increased risk of fractures, and we can use it to predict the fractures, as the third of radius right there. Points of interest here also, you would like to have the radius-ulnar point of overlap to be seen, and you have to have the ulnar styloid process here. Also, that will, if you see these two areas, then you can make sure that the image was done in a correctly, and positioning of the patient was done correctly also. So what does DEXA scan really measures? It measures bone mineral density, so BMD. And what is BMD? Is a content over an area. So it's a bone mineral density, or content of the bone itself, over the area that it was measured. So that's what the BMD is actually. So it's a grams per centimeter squares. So what is a T-score then? So T-score is a standard deviation. It tells you how far the patient's density is compared to someone who would have a normal density. Is he -1 far away from the mean? So that means he's only less 1. If he's +1 far from the mean, that means he's only +1 from the mean. So the more in the negative, then the more or lesser density the patient has. The more towards the positive means he's having even higher the density than the median normal. Okay, so that's this standard deviation, statistically, basically. And in the T-score, we compare the patient, whoever the patient is, whatever age he is, to the young normal population. But if we use the Z-score, then we use this patient's BMD value compared to his age. So if he's young, we'll compare to his young age. If he's old, we'll compare him to his age old. Okay? So it doesn't matter. I mean, yes, these scores we use them for young population, but it's basically using the same values of his age. So if I'm looking at a Z-score of someone who's 60 years old, then I'm looking at a Z-score of someone 60 years old comparing to other people at 60 years old. Okay? So Z-scores meaning comparing someone's mean or someone's BMD to his age group. So if they are 30, then we're comparing them to 30. If he's 60, then we're comparing them to 60. But with T-score, we're using the BMD of the patient, whoever the age is. Maybe you're scanning someone who's 70 years old to a young population. So that's the difference between a T-score and the Z-score. So in the basic information of the DEXA scan, very standard things you need to know. Just like if you're doing a prescription of a medication or on any imaging, definitely need to have a name, sex, age, heights, and weights, because they are important to calculating the risk of fractures and fractures, so you need these. And they are important also for the results demonstrations. Race is all important also because different races have risk of fractures that are differently. You have to review the images because we went through now what are the regions of interest and how they are labeled, and the points of interest that make you have a good judgment about the DEXA scan that was correctly. So you need to make sure that if your positioning is actually correct, as we mentioned. If you want to compare one DEXA scan to a previous DEXA scan, you also want to make sure that the regions of interest is exactly the same. Because we'll show you some examples of the region of interest has changed based on labeling is different or the space is different, will give you different results. Regions of interest are identified correctly. The markers are correct, so L1 is really L1, it's not T12, for example, okay? Identify if there is an artifact, we'll go through some examples of artifact. There are compression fractures, and we'll tell you how to diagnose these things. And degenerative changes, which are very, very common, especially if you do scans on an elderly population, you will see these differences. And we'll show you what do we mean by these changes. What about the DEXA graph? A DEXA graph is a kind of way or a tool to help patients understand where are the risk or where is his risk of fractures. But the problem is that this is all based on data that is not local data, basically. So if I'm using it to tell this patient that your risk of a fracture is right here on the yellow zone, so he could be actually, from our population, could be even better than that. So try to avoid this and maybe use FRAX to actually tell them what is your actually risk for fractures. It'll be more meaningful because you will use the FRAX Q80 model, which tell you more information. So what about the numerical data that comes up on the table? So what's important here is that when you look at the numerical data, there's certain steps you need to make sure. First of all, a normal progression of a lumbar spine going from L1 to L4 is what? Is actually increasing the size of the lumbar spine. So L1 is smaller than L2, L2 is smaller than L3, or the opposite, if you want to say. So L4 is bigger than L3, bigger than L2, and bigger than L1. So L4 would be the largest in terms and the higher density, and L1 should be the lowest of these three. So what you will see is that the area should increase. So that's a normal progression, 11, 12, 13, 16. The bone mineral content also should increase because the area is increasing, right? So 10, 11.4, 11.6, and 15. And the BMD also increasing because بالعربي بسطوا مقام تقريبا. So you're dividing, okay? So you have the two levels divided on themselves. So you also have an increase in the density. Sometimes in L3 and L4, you don't have the step up. And why? Because sometimes you will have the larger area, which is the denominator, I think, right? And then the denominator, you have it in a stable or slightly increasing. But because the lower value is much larger, then the ratio will be smaller, okay? So sometimes you see a BMD not going the right way, but maybe in L3 and L4 it's kind of slightly lower. But generally, you will see this progression going on from L1 to L4. So T-scores with that, they should be similar. I mean, the changes between these T-scores should be very minimal. So you see here 0.2, then here you can see 1.2, 1.9, 1.7. So what you see here is actually a difference between L1 and the rest of the vertebrae. And when you look at the T-score, to make sure that these correctly are labeled and correctly are healthy vertebrae, you need to make sure that there is no more than one standard deviation between these vertebrae together. So in this here, between L2 and L4, they're all within one standard deviation. But L1 is actually one standard deviation almost exactly away from them. So L1, it seems like it has an issue because, or L3 to L2 to L4, maybe they have the issue. So what could sort this out is actually looking at the image and looking at L1, seeing what's wrong with L1, why it's looking differently than the other vertebrae. Or maybe L2 to L4 have the abnormality based on the X-ray. So here, it's very important to look at the T-scores because you don't want to have more than one standard deviation between these values. Otherwise, then you will have abnormality in looking at these numbers. This is the extended numerical results, and they're helpful if you want to get the T-score of a spine, but you want to eliminate certain vertebrae because of improper values, basically. So for this patient, for example, I want to remove L1 because L1 seems abnormal. It's one standard deviation away from the other, from L2 to L4. The total right here is including with L1, so I want to eliminate it. So how do I do that? If we give you the extended form, so in this patient, I will look for L2 to L4. And this is a different patient, but it's just an example. So L2 and L4 for that patient would be the correct T-score because eliminating L1 because it has the misleading value. So this is the good thing about this extended numerical numbers. So you can do the exclusions if you want. This is also normal progression. This is minus 2.5, 2.3. This is still within one standard deviation. So all of them within one standard deviation still, even though they have normal value, different values. And looking at the images, you won't see any much pathology going on in these images. This one, on the other hand, is different. L1 looks like L4. L2 looks like L3. So what do? We look at the image. So what do we look about the image? L2 has a high density, right? There's something wrong here, and maybe a little bit something wrong here at these areas. So this is probably someone who would have arthritic changes, and this is how they will look like. They will have higher density, and the thickness of the spine or the height of the spine will still be normal. So, okay? Unless you will see that the spine actually flattens and becomes shrunken with the higher density, then this is most likely a fracture that is hidden, okay? So in this part, then, because there is more than one standard deviation, I have to do some eliminations. So which ones I eliminate? I look at the picture. I see L2 has an issue. L3 looks like an L2, even here by numbers. So I will exclude L2 and L3, and I will use L1 and L4 as my total spine. So how I do that, I go back to the extended numerical table, and I will choose L1 to L4, or L1 and L4, and it will give you a T-score of the total at that point, okay? In the hip, the ones that actually gives you meaningful clinical evidence is the one that is the femoral neck and the total hip measurements, because these are two regions of interest we mentioned in the images. The worst triangle, actually, right there, is not really an anatomical location. They are just because of the alliance of all these boxes that we do to look at the spine, the hip, and just the worst triangle is just triangle formed because of all these alignments. So it's not really a real anatomical location. So neck and total hip is the ones that actually we look for. And we just, here we don't look at standard deviation among them because they're two different areas and they are not even the same area because total hip is a much larger area compared to the neck. Third of radius, we'll look at only one location, which is third, and we'll look at the T-score, and we'd like to use the non-dominant arm in that method. What about reporting? Well, you can do your own reporting if you feel confident to do your own reporting, but you need to make a good judgment about reportings that comes to your table, to your desk, to your file, and you know that they are not correct. So one thing is you can make sure that they're not correct if they use some different terminology that are not appropriate to describe a DEXA scan. So one thing is not appropriate is to call someone had a bone loss unless you have a comparable result. Because you don't know if they had a really bone loss unless you show that they had a decrease in the value of their BMD. Otherwise, you cannot call that. You cannot call mild, moderate, or marked osteopenia or osteoporosis because there is no such definitions of these, okay? You can use a severe or established if the patient has a fragility fracture. Then you can use this term to describe a severe form of osteoporosis. You cannot use separate diagnoses to different regions of interest. You cannot say osteopenia of the spine and osteoporosis of the hip. Disease by itself composed of the whole body. So if they have osteoporosis of the spine, then they have osteoporosis everywhere because the risk of a fracture is equal to all these bones. A non-significant change in BMD when the least significant change is known. So this is very important also, and we'll talk about a little bit more details later on in terms of the least significant change. So what about VFA or vertebral fracture assessment? So it's a tool that we use to look at the spine, the whole spine, to see if there is any hidden fractures in the spine. We use the same DEXA technology, but we use a different little bit software, and the patient needs to be positioned in a different way. It comes from the same DEXA machine, and we can look at the spine to see if they have any hidden fractures in the spine. So this is how it looks like in GE and hologic. We just ask the patient to lay on his side, basically, and we can get the whole picture of the spine, basically thoracic and lumbar, because these the highest risk of fractures in these populations. So in this patient, for example, this is a normal, and this is someone who had T12 fracture. This is also normal. This is also very similar, maybe L1 or 2. This is probably L1, also fracture that you can detect by looking at the VFA. This is another example in T11. This is a normal. It requires a trained interpreter. So you need to have to look at many of these VFAs so you can actually, or you can ask a good radiologist to look it for you. The good thing about the VFA is that you don't have, if you suspect someone has a fragility fracture in the spine, you don't have to get him off the machine and take him to a different room where they do another scan or another x-ray. So you can do the whole thing at the DEXA scan itself. The indications of vertebral imaging, and we are in the Kuwait guidelines, we provided very similar to the international known ones. We'd like to do the VFA or looking at the vertebral assessing its fractures either by doing the VFA itself, and unfortunately not all hospitals do it. I know in Amiri they do it, and also the Jabbar, we're trying to start doing it also. But also you can do just a regular thoracic spine or lumbar spine. If you don't want to do the VFA or your technicians don't know how to do DFA, then you just do a regular x-ray of the spine, lumbar and spine. And we like to do that in women above the age of 70 and all men above the age of 80, because in these populations, the increased risk of developing hidden or silent fractures is large. And we'd like to pick them up because if they do have it, then they are labeled at high severe cases of osteoporosis. Also in women and men above the age of 50, if they had a previously low trauma fracture, if they had a historical loss of 4 centimeters, and they can tell you that I lost height. And if they do remember they lost 4 centimeters in height, then you need to look at their spine, see they make sure they didn't have a fracture. If you've been following them and lost, or you saw that they lost 2 centimeters in height, and these patients, you have to look at the spine, make sure they didn't have a fracture, or someone with long-term steroid therapy, also because these patients, especially in men, they could develop these hidden fragility fractures in the spine. What about follow-up scans? So reason to do a BMD follow-up on a DEXA scan is for untreated patients, you want to see if they lost significant amount of BMD. And you have these tables that show you how much percentage loss or gain even in the BMD. If you do successive DEXA scans, the machines comes out with telling you that the gain or there is a loss of 3% or 5% or 2% or whatever, either in plus or minus. So you can't actually track the amount of bone density those patients either gained or lost in untreated patients. In treated patients, you wanted to look and see the effect of your therapy. So if you're giving an anabolic agent, you expect the density will increase. If you're giving an anti-resorptive, it would also increase, but also it would stay stable, maintaining the bone density that they have. Patients should be encouraged to return to the same center for follow-up scan, and we also mentioned that in the beginning. We don't like to compare DEXA scans, different technologies. We'd like to do them in the same place. Now, there are some people who shift care, like they go totally to a different hospital or from private to government, from government from private. It might be not easy. So maybe if they started to establish care with you, maybe you want to establish the first scan with you and then take it further and do the follow-up later on. So that's what we mentioned. Oh, very important here is to compare the BMD, not T-scores. So don't say that T-score is getting better. You can say BMD is getting better, but not T-score, because T-score is just a standard deviation. It tells you where the patient is compared to the either younger or his age group. So BMD is the one that meets, is actually more linked to a risk of a fracture. So increase in BMD lowers the risk, loss of BMD increases the risk of a fractures. How much of a difference in BMD is real? So any change in BMD is normal or real. So 2% would be real. Is 5% real? Is a loss of 2% is real, or a plus of 3% is real? So all these numbers, how do we decide they are real changes? So you need to know the precision of at your center. This is probably shouldn't be the physician job unless you're dealing with all these DEXA machines because of a responsibility you have. But it should be a radiology department responsibility, is to know what is the precision, meaning how accurate is the DEXA scan whenever they repeat it every time. Does it come up always the same result, or it gives a different result every time? So that's what we call the precision. With the precision, this center or the DEXA or the radiology department should provide the least significant change. So what is the least significant change? It's the degree of variation in BMD reading in repeated testing to know if the difference is real. Meaning that you do a repeat of a testing of a DEXA scan, the BMD changes of 2-3%, for example, then how would you know this 3% is true result? Because for a glucose, for example, if I do 5.1 and 5.6, probably clinically means nothing, right? But in DEXA scan or BMD values, you need to know what would be in a normal or a significant result. So with this, we do this analysis to look for the least significant change. So it's something that the radiology have to provide for us. So least significant change equals a precision error that the radiology department has to establish times a cofactor, then it will give you the least significant change. So we'll give you an example of that. So a typical least significant change in the lumbar spine and the femoral neck would be somewhere around 3 to 4%, meaning any change in the lumbar spine that is plus more than 3 or 4% or negative less than 3 or 4% is a clinical value change. But if someone had a change of about maybe 1% or 2% gain or loss, then that's not meaningful. That's not clinically meaningful because it's within the least significant change. And the total hip is a little bit larger, about 4 to 5%. So this is an example. This is a baseline BMD of a patient who had in the spine a 0.866 gram per centimeter square. This patient had a repeat spine 2, 3, 4 years, whatever, and he had a BMD value of the same area, about 0.826. Now the difference is that this patient has lost, right? Because this is baseline, this is a follow-up, right? And he decreased. So he lost 0.04. So that would be about 4%, right? So is 4% loss clinically significant? Then the next thing you should know is that what's the least significant change? So if I tell you the least significant, so this is 4% the patient has lost. So if the least significant change is this center is about 3%. So does he exceed it or he's within it? So he exceeds the least significant change. That means his difference, yes, is true. So he really true lost 4%. But if he did lost, for example, 2% here, or gain 2%, then that's within the least significant change. That means that's nothing. Okay? So that's where we leave the, and it should mention it in the DEXA scan reporting. When you see, they should include that. And it should be in all the hospitals in Kuwait. Okay, so in follow-up scan, we always mention that always compare the BMD, not T-scores. You need to make sure that the region of interest also scanned correctly. The measurements area should be comparable. You need to make sure that the position are correctly, and these are the images. Just when you're looking at another DEXA scan, you do the same thing as you were doing in the first DEXA scan. So this is for examples for poor definition of the edges. This is someone who had a DEXA scan. This is different technology. Now, we don't have this machine. But this is the labeling or the edges of the vertebrae. You see here, they did not really get them correctly. There's some bone left over. And this is done correctly. Okay? So it gives you different value if you do it correctly. This is also important about the hip positioning. So this has had a baseline DEXA scan. Good positioning. It looks like an abduction, internal rotation very well. Box is good. It's anchored to the greater 2 contact because this is a halogenic scan. So everything looks good. This is his BMD value. Then after 2 years, he had another scan, and it showed that he had about only 0.8% gain, which is, and with any least significant change, that's nothing, basically, right? But what's so abnormal in this image is, so positioning is really poor, right? So you see the leg is abducted, and the lesser truncator is more appearing, that's more externally rotated. So the positioning of the hip is not done correctly. So this patient had a rescan and done correctly with the good definition of region of interest, and this patient actually lost 4.3% just because of correct positioning. Okay. This is also to look for a scan analysis when they give you the areas, also in the trending tables, when they give you the DEXA scan and the follow-up scans, they also give you the areas that were scanned, and we'll give you the first area and the follow-up area. Make sure they're very comparable. They don't have to be exactly the same, but comparable in terms of the area, because you don't want to compare a larger to a next year or next after a few years. You compare them with a smaller area. So the scan area should be similar. This is another example. This is a good follow-up of a spine. This is the baseline, good labeling of L1 to L4. The edges are done correctly. This is the BMD T-score of this patient. On a follow-up, okay, also looks done correctly. You can see the points of interest, the floating rib, the iliac crest, all of them appearing. This is correctly L1 to L4. Good follow-up, good results. You need to trust it, okay? This is not a poor follow-up, okay? This is the initial baseline scan, very similar to what we described. Floating rib is there, iliac crest on the sides, L1 to L4, good edges, good labeling. Even the lines between the intervertebral areas are done correctly. But what's wrong here? So what's wrong with the position? Tilted? Okay, but what's more striking? What about L1? L1. What is L1? Look at the rib. This is not L1. It's T12. Okay? So it was misplaced as L1. So what happened to the density in this guy? It will be lower because T12 has a less density than L1. So he will lose bone just because of positioning error. Okay? So this patient doesn't need to be scanned again. The analysis should be done again on this patient. Okay? So this is one of the issues that could develop when you look at the image. Make sure that it's just a regular X-ray when you see an X-ray of a chest X-ray, whatever. Just make sure that you're looking at the right X-ray, basically. Which site to monitor? So which one we check for monitoring of therapy, basically? This is for therapy mainly. Lumbar spine is preferred because major trials were done on spine, looking for the risk of a fracture reduction with therapy. And also it has the best precision, meaning mistakes with positioning in the spine is less. So it's easy to get the same results. Second option would be total hip. Third option, femoral neck, because it's more difficult. Forearm is not really good for monitoring therapy, and we don't use it for that. How often we test? We test about maybe 1 to 2 years after initiating or change of therapy. Then similar or even longer if it needs to. If no therapy is indicated, then it still depends on the clinical scenario, but maybe somewhere between 3 years to up to 5 years. Clinical prevalence, increasing in BMD is encouraging. It tells you that probably things are going well with this patient. If it's done correctly, everything's done correctly. A stable BMD is also okay, but the decline or decrease in BMD is a problem, and you have to look for reasons. So if they are on therapy, you need to look for compliance. If they're not on therapy, or even on therapy, you need to look for secondary causes of bone loss. DEXA scan, this is just images. We'll go through them, and we'll see what the error is here. So a positioning pitfall. So this is a tilted. We'd like them to be non-tilted so we can have a better view. This is off-center. We'd like to have them centered because they're placed on the table to be in the center position. We don't have this, so we'll skip that. Poor edge detection, this we also mentioned this. So you can see here is actually moving away from bone, so getting less, actually more of a soft tissue into the measurements. This is actually going through the bone and losing a lot of bone from edges. This is scoliosis, and you have probably seen patients done DEXA scan like that. And these patients probably should not really look at their spine because it's completely abnormal. Okay? So you skip the spine in these patients and go for the hip and the forearm. This is an artifact. This is actually what we call the possible fractures of the spine. What you see here, the increase in density, and what else you see? The reduction in the size of the vertebrae. So this is very characteristic of a fracture. And if you see this, you have always make sure that the patient done a spine X-ray or from the VFA if they have to look for these hidden fractures. Okay? So increase in density with loss of height, it's a fracture unless proven otherwise, if I can say that. Okay? And this is also a fracture, maybe not much loss of height, but also could be this is also in the case another compression fracture. This is GI contrast. You can see the column filled with contrast. So it's actually increasing the density of L3 here. So it's not the right time to do DEXA scan on this patient. This is after 2 weeks, all clear. This is ankylosing spondylitis. You can see the calcified aorta and all the calcification in the soft tissues. This also will increase the density of the spine. So these patients may be not quite good to do a spine DEXA scan and maybe do a hip DEXA scan. This is augmentation. So in this patient, if you look at the L3, look at the T-score, plus 14. This is because of the solid material that they introduce in the spine, okay? So definitely you need to eliminate L3 in this patient. So you need to skip it from the extended numerical table. You just exclude L3 and look for the other totals. L4 looks like it has a problem too. So this is probably needs to be looked at also. This is had laminectomy. So what happens with a laminectomy? You actually lose density, right? Because part of the bone is lost. So actually lose bone. And this guy in L4, you can see the density is actually lower in L4. So this is someone also you exclude with the L4. So here this is excluded from the spine. This is a prostate cancer metastasis. So this is a baseline. And later on, 2 years later on, actually much higher density, maybe not much less of loss of height, but with increased density in the background that he has of a cancer, especially breast, colon, prostate cancer, which really love going to the bones, then maybe this is something you want to look for, a hidden metastasis in this patient. Spine artifact could be the brow wires could be showing, gallbladder clips here, calcium tablets, and large gallstones. A lot of these might not really affecting the density, but just something that you probably will see maybe on an X-ray of the image of the DEXA scan and just wonder what it is. This is the abduction. Adduction will be mentioned. So this is an improper positioning also of the hip. This is also someone who has a hip osteoarthritis that actually makes the internal rotation is very hard for this patient. So he probably will have his hip actually more of externally rotated just because he cannot just internally rotate his hip. This is the poor neck box placement. As we mentioned, this you can see here, completely off place. This is correctly. This is not a repeat scan. This is just a repeat analysis. So here, just maybe I think this is the last slide. So in terms of the artifacts, and this is important, this part is very important here. So degenerative changes will only increase your BMD value. And by this, T-score will be better, more positive, right? But with fractures, you will have higher density with less height if we're talking about the spine. And these patients, you need to make sure they did not have any fractures. Avoid scanning a fractured hip or a forearm. And in metals, you can have some metals there. We already mentioned them. And some of the other ones, we already showed the pictures of these of these artifacts. So thank you so much.